welcome everybody to this event with a combined event between Lincolnshire Training Hub, Lincolnshire LMC and LPFT. I'd like to introduce Dr. Praveen Kumar.
Hello everyone, good evening. My name is Dr. Kumar. I am a consultant psychiatrist. I've recently joined Lincolnshire Trust. I used to work in Cambridgeshire and Peterborough Mental Health Trust for several years. I've been a consultant for around 12 to 13 years now, and most of my work has been, majority of my consultant experience has been in inpatient psychiatry. In fact, I think all of it has been inpatient psychiatry, so I don't have a lot of experience in outpatient, CMHTs. I've recently been appointed as a clinical director for inpatient division in Lincolnshire, and I'm currently working in a psychiatric high dependency unit in Lincoln. So depression is considered as a heterogeneous syndrome. It's an etiologically complex psychiatric syndrome. It's not a unitary disease entity. It encompasses a broad spectrum of psychopathology arising from distinct pathophysiological mechanisms. The heterogeneity is not just in the phenotypic subtypes we see, but it's also even the genetic predisposition is a polygenic inheritance pattern that we see in depression. So these are some of the reasons why we call it complex and heterogeneous. A lot of you might have heard of endogenous versus exogenous depression. During the 80s, people believed that the depression is of two types, that's exogenous and endogenous. The idea was that the difference between depression precipitated by life events were called as exogenous, so factors outside the body, and the endogenous depression was considered as a inherent physiological disorders. And the significance of this demarcation in those days was that people believed that the endogenous depressive people responded better to treatment. We've done away with this exogenous and endogenous business anymore. We don't use those terms anymore. Then the complexity also arises between the prototype depressive person that we see versus the atypical presentations. The typical ones that we think of is someone who is quite withdrawn, passive, and psychomotorly retarded, with poor sleep and loss of appetite, etc. On the other hand, you also can see the atypical presentations. People can present with hypersomnia, excessive eating, weight gain, agitation, etc. The DSM also talks something about melancholic depression, whereas ICD doesn't. And then we got the psychotic depressive type. Just a point to make here. When someone with depression presents with psychotic symptoms, the depression should have been so severe. So in terms of diagnostic categories, there's nothing like moderate depression with psychosis. The depression has to be severe to be accompanied by psychotic symptoms. Then there's the unipolar and bipolar type. We will be talking about the difference between unipolar and bipolar in a minute. And patients can present with various other symptoms as presenting complaints, like somatic symptoms. So patients who present with predominantly somatic symptoms may be very resistant to accepting that they are actually depressed. And I think it's important to explain to them that, the somatic symptoms might be a result of an underlying depressive illness. Some people can present with predominant anxiety and panic attacks. While the treatment of depression is a priority, I think it's also important to simultaneously educate the patients about the context of the anxiety, which is coexisting with a depressive illness. Some patients can present with obsessional traits as presenting complaints. People with these obsessive traits often become very severely obsessional in their behavior, and the depressive ruminations can be quite disabling. And most of you might have heard about pseudodementia. So this is a condition where which is seen in older people. Depression may present as an apparent dementia, but the presenting symptoms usually turn out to be due to inattention and impaired concentration. So, as you can see from this slide, the estimated heritability of mental illness that we see, if you compare major depression with, say, autism or schizophrenia, the heritability is only 40%, which suggests that there is a huge environmental factors involved. And this is an illustration of all the possible environmental factors that can be seen in etiology of depression, ranging from air pollution to noise pollution, economic status, urbanicity, contamination, pollution, like heavy metal poisoning, and natural disasters. It's quite contextual now because we are seeing a surge of patients with anxiety disorders even in secondary care, and there are lots of people who are relapsing because of isolation due to COVID restrictions. And you also can see climate change thrown in there. So how do we screen people for depression in primary care? I'm sure you're all very familiar with the screening tools. The most commonly used ones are PHQ-2 and PHQ-9. They are based on the DSM diagnostic criteria. While screening patients, be aware of bipolarity. 50% of patients who eventually develop bipolar disorder, or diagnosed with bipolar disorder, would have been treated as unipolar depression for a long time, either in primary care or secondary care. So be aware of bipolarity. We'll talk about the differences of bipolar and unipolar in a minute. Be aware of bereavement that can lead to depressive illness. And one of the most common dilemmas you might come across is differentiating emotional instability from a persistent mood disorder. So the key point there is pervasiveness of the low mood, whereas people with emotionally unstable personality disorder or people with traits of emotional instability usually have the mood changes quite rapidly within hours, days. Be aware of substance misuse that could be complicating a depressive illness, and always ask about any recent start of medications. The most common ones we see are beta blockers, statins, steroids, etc. So how do you differentiate unipolar versus bipolar? The important thing that we see is the cyclic nature in bipolar compared to the dysthymic picture in unipolar depression. Whereas depression is more in women than men, This tends to be equal in bipolar depression. And the age of onset is pretty early, quite early compared to unipolar depression. The onset is often quite abrupt in bipolar, whereas in unipolar, it's more insidious. There'll be a number of episodes of bipolar sort of depression before a diagnosis is made. The atypicality seems to be a feature of bipolar. You would expect agitation, but in bipolar depression, it's more of psychomotor retardation and hypersomnia rather than insomnia. And obviously, a positive family history of bipolar disorder would indicate bipolar depression. So PHQ-2 and PHQ-9 are self-reported tools, self-rating scales. They are extensively studied and they've got a very good validity. I think the specificity and sensitivity both are at around 90s for PHQ-9. In terms of diagnosis, DSM-4 is quite simple compared to ICD-10 for depression, and NICE guidelines also use DSM-4 in their guidance. So I put the criteria there. So on the right, you have 9 symptoms, and the top 2 are in red because they are mandatory. So for a major depressive episode, patient should be suffering from 5 or more of these symptoms for more than 2 weeks, at least 2 weeks. So as I said, the depressed mood and anhedonia are a must, and it should come with significant distress or impairment in functioning. And the exclusions are that they shouldn't have had a manic or hypomanic episode in the past. Minor depressive episode is diagnosed when patients have 2 to 4 of these symptoms for more than 2 weeks. And again, depressed mood and loss of interest or pleasure are a must. And it should be causing significant distress or impairment. And again, the exclusions are manic or hypomanic episodes. There's also something called dysthymic disorder that we should be aware of. A lot of times it can be sort of confused with some sort of a depressive personality, someone who's been sad most of their life. But this is a distinct diagnosis, and it's important that we are aware of it. So the patient should have had depressed mood for most of the time for at least 2 years. And there shouldn't be a period of more than 2 months where they don't have these symptoms. And again, symptoms must cause significant distress or impairment in their functioning. And there shouldn't be a major depressive disorder in the first 2 years for this diagnosis to be made. And again, as always, there should be no manic or hypomanic episodes in the past. The symptoms of these are depressed mood, along with these 6 symptoms: significant weight loss, insomnia or hypersomnia, a change in appetite, low self-esteem, and impaired concentration, attention, and feelings of hopelessness. Then we come to mixed depressive and anxiety disorder. I think the most commonly diagnosed mood disorders in primary care. It is a controversial diagnosis. In fact, the latest edition of DSM, the DSM-5, have done away. They didn't include this diagnosis, whereas ICD-11 still has mixed depressive and anxiety disorder as a diagnosis. So when can we diagnose people with mixed anxiety and depression? They should have symptoms of both anxiety and depression for more than 2 weeks, but the symptoms are sub-threshold for a diagnosis of either a major depressive disorder or an anxiety disorder like generalized anxiety disorders. So neither set of symptoms considered separately is sufficiently severe, numerous, or persistent to justify a diagnosis of a major depressive illness or a generalized anxiety disorder. So patients should present with depressed mood or diminished interest, plus additional depressive symptoms, plus multiple symptoms of anxiety. And again, these symptoms should be causing significant distress or impairment. And the usual exclusions are again bipolar disorders like manic episodes or hypomanic episodes. Coming to the management of depression, NICE guideline says you have to offer psychological interventions before we consider medications. Lifestyle modifications and psychological interventions are the first line treatment for mild to moderate depressive illness. Apart from the psychological interventions and medications, we have a range of brain stimulations available, but that is reserved for secondary care. Other than the commonly used brain stimulation like ECT, there is an increased interest in other modalities of brain stimulation like repetitive transcranial magnetic stimulation. And there's also a deep brain stimulation that people use quite a lot in America. And there are various other variants of the transcranial magnetic stimulation that have been developed recently. The NICE guidelines talk about stepped care model. I'm sure most of you are aware of this. So basically what it says is you got to treat depression in a stepped care model, starting from psychoeducation, lifestyle modifications, advice, and monitoring, wait and watch to see if the symptoms resolve. And then the second step would be low intensity psychological interventions and probably medications if needed. I think when it comes to step 3, I think this is where you might want to start thinking about discussing with a specialist if symptoms are not being resolved. And step 4 is certainly reserved for secondary care, psychiatric admission and ECT. So around 10 years ago, government has taken on this prestigious improved access to psychological therapies. And this is a report from 2019 to 2020. As you can see, looking at the numbers, around 1.7 million referrals have been received by IAPT across the country. But then if you look at the recovery rate, it's about 50%. So out of the 1.7 million, around 600,000 people have completed a course of treatment. And out of the 600,000, 51% made it to the recovery. I mean, you can judge the efficacy of this this large-scale intervention. I know countries like Sweden and the Dutch are interested in implementing a similar interventions in their countries, but there's lots of criticism as well about the attrition rate and the dropouts. But personally, I think there was a time when NICE guideline stipulated that we try out psychological therapies before considering medication, but then none of them were available. There were long waiting lists. I'm not sure what the waiting lists are now. You guys might know better than me, but as the numbers speak for themselves, how effective this is. So coming to antidepressants, there are certain basic principles that we all should be aware of before considering initiation of pharmacotherapy for depression. As I mentioned, patients actually engage better in the treatment if they are provided with information and choice, including non-pharmacological treatments. Patients should always be warned about the time it takes for resolution of symptoms, and always try and limit to effective minimum dose to avoid adverse reactions. The length of treatment depends on whether this is a single episode or multiple episodes. If someone has a single episode, it's recommended that we continue antidepressant therapy 6 to 9 months, even after the remission of symptoms. For people with multiple episodes, the general rule is we at least have 2 years of symptom-free period before we consider tapering the medication and stopping. When stopping, always withdraw the drug gradually. Educate the patient about risk and the nature of discontinuation symptoms from antidepressants. SSRIs are always the first line antidepressants as per the NICE guidance. It also says you can try other drugs like mirtazapine as first line in case the SSRIs are contraindicated or risky in certain populations. Patients usually tolerate SSRIs better than tricyclics. I don't think we need to discuss anything about monoamine oxidase inhibitors. These are usually reserved for secondary care in resistant depression, treatment-resistant depression. And I wouldn't really advise any of the primary care clinicians to initiate MOAs in the primary care. Certain antidepressants have got very well-known side effects, like paroxetine is associated with weight gain and sexual dysfunction. Sertraline has got more GI symptoms than other SSRIs. The dual reuptake inhibitors are less tolerated than SSRIs. All SSRIs cause GI upset, sexual dysfunction, in addition to headaches and GI bleeds. Almost all tricyclic antidepressants are cardiotoxic, and all antidepressants, as a rule, can cause discontinuation syndrome. Always warn patients about the possibility of suicidality when starting or stopping antidepressants. All antidepressants are implicated in this. Young adults and adolescents are more affected. It's important to point out to patients that the absolute risk ratio is still small, and on balance, all antidepressants reduce suicidality in general. So when you're initiating or stopping antidepressants, beware of the possibility of worsening suicidal tendencies. And if you come across patients who complain about feeling more suicidal when during the treatment, it is advisable that primary care clinicians follow up the patients on a weekly basis until the suicidality improves. So this is a chart listing adverse effects for all antidepressants. As you can see, loss of libido seems to be quite common. However, this is one symptom that patients rarely discuss, and it's important that we are aware of it and try and ask these questions in a sensitive way. So this is by Cipriani et al. In Lancet, talking about tolerability and acceptability of antidepressants. And as you can see, fluoxetine, I think it's because it's the most studied SSRI we have. On top of it is agomelatine that we don't advise primary care physicians to initiate in any way. So what does NICE guidelines say for starting antidepressants? So as always, try psychological therapies for mild to moderate to start with. And if medication is indicated, then the first line should be SSRIs. Usually citalopram, fluoxetine or sertraline or the preferred choices. Beware of any concomitant, medication that patients are already taking, and look at potential interactions of SSRIs with them. Patients under 18 years of age, fluoxetine is the only recommended antidepressants. I think it's licensed for treatment for moderate to severe depression from 8 years onwards. When initiating citalopram, beware of the QT interval changes. And certainly when citalopram is prescribed at around 40 milligrams, I would advise you have a baseline ECG. So for any reason, if the first line drug is ineffective or is not tolerated, try an alternative SSRI or venlafaxine or mirtazapine. So both venlafaxine and mirtazapine can be initiated in primary care. When you consider venlafaxine as your next choice, beware of hypertension and also QT interval. I would suggest having a baseline ECG before starting venlafaxine. In fact, when venlafaxine was first introduced, it came with a warning that every patient who starts on venlafaxine should have a baseline ECG, but that's been withdrawn now. I don't think you would go to the third line anyway. And vortioxetine is definitely, it comes with a warning that it has to be initiated only on advice, after an advice from specialists. And combination, it should be reserved for secondary care, in my view. I think NICE guidelines also says for specialist initiation only. So don't combine antidepressants in primary care. So always think about underlying physical illness and medication that patients are already taking for their physical illness. These are some of the common examples that we need to consider. Try and avoid SSRIs when someone's taking non-steroidal anti-inflammatory drugs because of risk of bleeding. If there's no choice and you had to consider SSRI, consider starting them on a proton pump inhibitor. Warfarin or heparin, definitely you've got to be very cautious to combine with SSRIs. So as you can read through, I mean, clozapine, I don't think you will be starting any antidepressants with people who are already on clozapine because they probably are under secondary care anyway. The triptan drugs do not offer SSRIs when someone is already on treatment for migraines. So this is an example of switching antidepressants. When switching antidepressants, there are certain principles that we need to be aware of. You got to consider individual patient circumstances when you're switching, the urgency of the switch, how severely patients are depressed, the patient's physical conditions. Caution is always required when you are switching antidepressants in elderly people. The current dose of first antidepressant dictates how quickly you can taper. The longer the duration of treatment with antidepressants, the more likelihood of discontinuation syndrome. You got to consider the pharmacodynamic and pharmacokinetic profiles of antidepressants involved to determine the rate of the switch. Always be aware of the risk of serotonin syndrome. It's more likely to occur if the patient is on a drug therapy with serotogenic activity, as well as any other drugs that they're taking, like opioids, tramadol, lithium, etc. Always ask about any history of discontinuation reactions in the past. This is just an example of how you can cross-taper. This is the safest way to do. Always consider cross-tapering rather than a direct switch. And the tapering is always, and the cross-taper is always dependent on half-life. You take into consideration the half-life of the drugs when you're switching. For example, if you look at the common ones, are fluoxetine that we can talk about. Fluoxetine has got a long half-life. So when someone is on fluoxetine and you want to change that to, say, a tricyclic or say mirtazapine, what you do is you consider, you got to bear in mind that there is still the active metabolite in the system for a long period, usually for a week or 10 days. So if you rapidly increase the new drug, the possibility of serotonin syndrome is high because there's already a significant amount of fluoxetine in the system. So beware of half-life. Have a chart of half-life of various antidepressants. That can help you in planning the switch. So some of the common strategies when you're switching from an SSRI to other SSRI, if it's usually other SSRI, a direct switch is possible, but again, individual circumstances should be taken into consideration. Always consider cross-taper as a safe way, unless the need is really urgent, in which case you're going to ask for some advice from your local psychiatrist anyway. And I won't go through the whole chart, but the principles are that you take into consideration half-life of both the drugs, look at individual circumstances, the patient characteristics, the severity of the depression, the urgency for the switch, and you can plan accordingly. So the more recent guidance actually makes it even more difficult. The current thought is that discontinuation syndrome is far more common than we actually recognize. A lot of times it can be confused with the symptoms of depression itself, like agitation, etc. So the Royal College recently has come up with this thought that, you know, we ought to be tapering off antidepressants far more slowly than we normally did. In fact, they actually ask us to change it into liquid, so smaller doses can be given. I don't think this is common practice yet, but it's increasingly gaining importance. So this is a slide about discontinuation syndrome seen when patients are withdrawn from SSRIs. There's a range of symptoms, and that's why it's easy to miss. I mean, it can present something like flu-like symptoms to more serious symptoms like paresthesia, visual disturbances, tachycardia, dizziness, confusion, and sexual side effects as well. The most common ones that we see are irritability, confusion, headaches, and the GI symptoms. So this is a chart showing the risk of withdrawal effects with various antidepressants. The most common ones we see are from venlafaxine and paroxetine in our practice. As you can see, fluoxetine seems to have low risk, and agomelatine I don't think will be used in primary care anyway. So fluoxetine has got low risk, but most of others are either moderate risk or high risk. So be aware of serotonin syndrome. It can be a mild to severe form, and those are the symptoms that you see usually. The classical symptoms would be hypothermia, rigidity, and confusion. We don't normally see the classical triad of, myoclonus, diaphoresis, and hypothermia. They can present with some symptoms, or it can be very mild that we miss. It's usually seen when patients are initiated an antidepressant and titrated quite rapidly. There was a video recently on Twitter, and I'll see if I can show you that, of a patient with this is actually from yesterday. There was a Twitter video, and it shows a patient with serotonin syndrome brought to ICU. If you can see the hyperreflexia, and it also presents. They're also present with myoclonus, classical myoclonus, and it is a serious condition that needs immediate medical attention. So some of the common side effects of the SSRIs, TCAs, as you can see, the tricyclics, the most common concern that we have is cardiotoxicity, conduction defects, and postural hypotension. Anticholinergics are classical of tricyclic antidepressants. They used to be the mainstream treatment until the use of SSRIs became common, and you can see all of them have got a range of adverse effects. So that's the reason why we prefer SSRIs. Although in terms of efficacy, I think they are as efficacious as SSRIs. They are poorly tolerated. In terms of SSRIs, the most common ones are GI symptoms. All of them have got GI symptoms and sexual dysfunction. And the other atypical antidepressants, as you can see, venlafaxine has got less sedation compared to mirtazapine. The ones that you commonly use or duloxetine, mirtazapine, and venlafaxine. Trazodone is very sedating. And in terms of sexual dysfunction, patients on venlafaxine do complain of serious sexual dysfunction. So cardiac adverse effects. When patients having underlying cardiac disease, always consider SSRIs. They are preferred. Avoid tricyclics, as you've seen in the previous slides. They've got conduction disorders and blood pressure, postural hypotension. Be cautious when we're prescribing antidepressants in arrhythmias because of the prolongation of QT interval. Citalopram is a classical example. Post-MI patients, depression is very common, and sertraline and mirtazapine are the preferred choices. In general, non-tricyclics have very low risk of inducing arrhythmias, but beware of the fact that QT prolongation is seen in some of the SSRIs. And as mentioned before, beware of hypertension when prescribing venlafaxine. This is a slide talking about QT interval risks with various antidepressants. As you can see, fluoxetine and sertraline, the most commonly initiated antidepressants in primary care, they both have got low risk of QT prolongation. The high ones are amitriptyline. So be cautious when patients are on amitriptyline. So coming to liver disease, tricyclics, almost all of them have first pass metabolism. And so in liver dysfunction, be careful of using tricyclics. It's usually thought that, antidepressants, the SSRIs are usually safe in liver disease. SSRIs, antidepressants, are the most studied, and they are recommended in patients who are pregnant. So there are certain general principles that you need to be aware when prescribing pregnancy. There's no definite association between malformations and use of SSRIs in pregnancy. This has not been confirmed, so SSRIs are advisable. Some studies have shown association between SSRI use in pregnancy and an increased risk of spontaneous abortions. The odd ratio is still small. They're also associated with low birth weight and preterm delivery, but data is conflicting, and it's unclear how common these outcomes are. Persistent pulmonary hypertension has been found to be more likely to affect newborns exposed to SSRIs in pregnancy, especially if SSRIs are given after 20 weeks of gestation in comparison with general population, but absolute risk is still low. There's a transient neonatal withdrawal syndrome seen in patients who have taken SSRIs in pregnancy. The neonate can present with symptoms related to, respiration, central nervous system symptoms, and gastrointestinal symptoms. TCAs are not well studied in pregnancy, and there's a possible association of TCA with preeclampsia, spontaneous abortion, preterm delivery, and autistic spectrum disorder. When it comes to breastfeeding, paroxetine and sertraline are the SSRIs of choice. Compared to other SSRIs, they have shorter half-lives and lower passage, lower concentration in breast milk. Although fluoxetine has a significant amount of published evidence for this, it is a very long-acting antidepressant. Its half-life is big, and the risk of accumulation in the breastfed infant is high. So sertraline and paroxetine would be the choice. When you prescribe paroxetine, it's notorious when it comes to discontinuation, so be aware of that.
We have got quite a few questions here. Some of them are really interesting. So I will just move on to the first question we have here. The first question is, do the treatment rates for IAPT refer to a specific treatment course such as one-to-one course of CBT, or do they refer to all interventions including self-help measures? Is there any good evidence for the effectiveness of the self-help measures?
I don't know the stats exactly, but there is a huge evidence for self-help. And I think one of the recent studies show that primary care clinicians are very good in referring people to self-help psychological interventions. And yes, it's not just about one-to-ones. I think there is group CBT, there is self-help, there is computer-aided CBT. So it's not just one-to-ones, Ashad. There is very good evidence for self-help CBT as well.
And I think there are some other resources as well. In Lincolnshire, we know that people can self-refer to Steps to Change. Yeah. And there's a recovery college as well that one can access to online. So that is also quite useful resource.
Yes.
Sure.
Thank you.
Thank you. The next question is, Dr. Kumar, patients on long-term SSRIs, where it's not possible for patients to manage without them, what do we need to be wary about when we do the annual medication review? Yeah. And any long-term side effects associated with the SSRIs?
Yeah, so there's not a lot of published studies on how long someone needs to be on SSRIs, but we know that when patients have multiple episodes of depression, we need to have at least 2 years of symptom-free period before we consider tapering off the antidepressants. When patients are on antidepressants for longer than 2 years, there's no guideline as such stipulating what needs to be monitored, but it depends on the type of antidepressant one is. For example, if someone's on mirtazapine for several years, you got to be careful about weight gain and all the metabolic side effects that come with weight gain. Similarly, if someone's taking venlafaxine for a very long time, you got to be monitoring the blood pressure. And if someone's taking an SSRI like citalopram, again, monitoring the QT interval at least once a year.
Yeah, there is a relevant question, which is about when is the best time to stop antidepressant?
Yeah, again, it's patient choice, but I don't see any clinical utility in using antidepressants for 4 to 5 years, because I can't see how someone can be maintained on an SSRI or an antidepressant for more than 2 to 3 years. In case of dysthymia, there are cases when we suggest continue indefinitely. But other than that, I think you need to sort of explore the reasons why someone is on antidepressants for more than 2 to 3 years.
Yeah. We have a question here. Which is the safest antidepressant in pregnancy and breastfeeding? I think you have answered that already.
Yeah, sertraline and paroxetine. Yeah.
Yeah, that's right. Thank you. The next question is it safe to prescribe SSRI to patients with severe depression who are alcohol dependent?
Yeah. So the problem with alcohol is that, due to the lifestyle, smoking, etc., you got to be careful about the GI side effects. Be aware of gastrointestinal bleeding, prescribe a PPI, but it's commonly prescribed. Yeah, SSRIs. We do still commonly prescribe SSRIs in people with alcohol dependence.
Sure.
But when it comes to substance misuse and people are taking methadone, I think we've got to be cautious with SSRIs. Any serotogenic activity along with methadone, you got to be wary of serotonin syndrome and also QT interval raise.
Yeah. I understand that why this question being asked is there's a general understanding that use of alcohol leads to more anxiety and more depression in itself.
Yeah.
So in some ways, it could be the triggering factor or a perpetuating factor. So without removing it or getting it out of the way, if antidepressant could be the right answer. So
exactly. I think the primary problem probably could be alcohol dependence, which is impacting on someone's mood. So we got to remove the underlying, primary factor, that is alcohol abuse. So it has to be a two-pronged approach while addressing alcohol misuse along with managing depression.
Yeah, makes sense. Would you recommend an ECG as baseline for everyone on citalopram?
It's not mandatory, but I would suggest that you have, if you have to increase more than 20 milligrams of citalopram, I would suggest take an ECG.
Because it's dose dependent, yeah.
Yeah, it's dose dependent QT, right? It's similarly with venlafaxine. As I said, when venlafaxine was introduced first, we used to do ECG for everyone before starting venlafaxine. Although the requirement has been taken off, but if someone who you're considering venlafaxine for also has comorbid cardiac comorbidity, you definitely have to do an ECG.
Yeah. When you're talking about venlafaxine, there is another question here about how often do you need to do ECG if somebody has got heart problems and venlafaxine together going in?
Again, there's no stipulated guideline on how frequently you do venlafaxine. I mean, generally you do a baseline. If someone's got cardiac problems, you do a baseline ECG anyway before starting any antidepressants. You've got to have a baseline ECG.
Sure.
In specific antidepressants like citalopram or venlafaxine, I would suggest you repeat an ECG after you achieve the therapeutic dose and see if there's any changes in the ECG. When it comes to tricyclic antidepressants, which I'm sure none of you would be initiating in primary care, but if you get patients who come from secondary care who are already on antidepressants from this class, the tricyclic antidepressants, it's important that if they have an annual health check, you include ECG as mandatory for them.
Okay. So there is another question. It's in regards to accessing for some advice. What is the best way to ask for advice from a local psychiatrist? Email or some letters?
Yeah, as I said, I've been only in this trust for a couple of months, so I really don't know the system here yet. But I think there are primary care layers and nurses based in the primary care. that's how it is in Cambridge. We have what we call as primary care psychiatric layers and nurses. And these nurses are based in some of the GP surgeries. I can find out and let you know if there is an email that you can use. But I would suggest calling a sector psychiatrist. Most of the psychiatrists that I know are more than willing to sort of offer phone advice for GPs.
Sure. This is a question about the liquid antidepressants.
Yeah.
It is somehow a bit difficult from the primary care to initiate it or to change it to liquid.
It is.
For someone, age, if it is, the tablet is not age appropriate, or it's an elderly patient having some swallowing problems.
Yeah. So that slide, I put that slide just to illustrate the importance of gradual tapering. It's not included in NICE guideline yet, that you change it to a liquid before you stop. This is something that's come up in the recent couple of years. It's gone big in Australian guidelines and other countries, but it's not come to us yet. So the principle is the care and caution that you take when you're tapering, and it has to be as slow as you can, unless there is an urgency to switch because of the severity of symptoms. In any case, you would be seeking specialist help in those circumstances.
Yeah, it's a question about bupropion, Dr. Kumar. A patient requested bupropion, says gaining weight on other SSRI. Is this used in secondary care? And I will add on to this question because I had a patient who came from abroad, who used to be on bupropion and asking for the prescription. So if a patient comes to a general practitioner asking for the prescription of bupropion, who hasn't been known to the secondary care team, do we need to refer to secondary care to carry on prescribing?
I would suggest you refer to secondary care. Bupropion is quite widely used in America. I'm sure your patient come from America.
That's right.
Yeah, I would suggest you refer for a specialist advice for that.
Sure.
Yeah.
Okay. Thank you. We have many patients on amitriptyline for neuropathic pain and on SSRI for depression. Is this acceptable?
Yeah. So it depends on the dosage. I think for neuropathic pain, you don't go beyond 25 to 50, isn't it?
It varies. It varies. We don't initiate higher doses. That's just my experience. But sometimes they are referred to the secondary care. They see the pain management team and they can initiate the higher doses as well.
Yeah. Look, combination of an SSRI and tricyclics is actually widely practiced in other countries. In several countries, it is a widely accepted practice. But theoretically, if you look at pharmacology of TCAs and SSRIs, I think the side effect burden is high with the combination, and the dropout rate would be high if with this combination. But if someone's already on amitriptyline for neuropathic pain and you have to start them on SSRIs, just exercise caution in tapering up the SSRI. Again, it depends on the existing dose of amitriptyline. Be aware of the cardiac side effects when you're combining, especially acute interval and conduction disorder defects. So one other thing you can do is, if someone's really needed an antidepressant, you might consider increasing amitriptyline rather than adding an SSRI to that. Amitriptyline is still a very good antidepressant, to be honest. So that would be one strategy. Or you want to try something like duloxetine, which is also indicated for neuropathic pain. So you can come off amitriptyline and switch to duloxetine.
Yeah.
But in small doses, I've seen numerous patients in secondary care who are quite stable on a small dose of amitriptyline and an SSRI.
Yeah. There is another question. What is the advice on SSRI in patients on NOACs or DOACs? Is there an increased risk of bleeding too?
Sorry, what's NOACs?
Rivaroxaban, apixaban.
Okay. Yeah.
Given
Yes.
for atrial fibrillation. Yeah.
Yes, certainly. There is an increased risk of GI bleeding with the combination of an SSRI with with an anticoagulant or blood thinner. You definitely increase the risk of GI bleeding.
Yeah.
It could be postpartum hemorrhage. It could be intracranial bleed. It could be just a GI bleed. So all serotonergic agents increase bleeding tendency. Yeah,
that makes sense. As you covered about NSAIDs and SSRI together.
Yeah.
But if somebody is on SSRI and as well as a NOAC or on NSAID, should they be on a PPI cover?
It should be on a PPI cover. And if it depends on how bad the comorbid bleeding disorders or whatever they are, you can ask for the community psychiatrist to consider switching it to a TCA, tricyclics.
Yes. Is it appropriate to initiate or prescribe fluoxetine because you covered about fluoxetine in children or younger patients, it's licensed. So is it appropriate to initiate in the primary care for a child or adolescent?
For adolescents, yes, you can. I think the NICE guideline says that anyone under the age of 16, you have to have a discussion with a specialist.
Sure. Okay. I'm just quickly scrolling through lots of questions. There are plenty here. And Dr. Kumar, there is another question which had been sent by a GP colleague. And the question is, I have come across with few male patients complaining of having erection problems and loss of libido being on SSRI. I have tried, I changed the SSRI to another, but still complaining of the same symptom. Is there any better solution to that?
Yeah, so we know very well that SSRIs can cause various sexual dysfunctions, including erectile dysfunction, problems with ejaculation, and loss of libido. The critical thing is you need to sort of explore if some of these symptoms are actually due to depression itself, or is it the SSRIs that is causing. So there needs to be a lot of exploration about, when did the symptoms start? Were they present even before the SSRIs were started and just got worse with SSRIs? In any case, you can't leave them on SSRIs if they're really struggling. So you can consider something like mirtazapine.
Yeah.
Yeah. And if the symptoms are not resolved, I think there are other options like vortioxetine, etc. So you can refer them to secondary care.
Yeah. Okay. The question is, which are the most effective SSRI? Before you answer to that question, I think you have covered at least partly that the SSRIs or medications, antidepressants are prescribed on the basis of any previous use, past response, if patient had any allergies previously to the certain medication or SSRI, you cannot prescribe it. Similarly, any existing comorbidities would be a factor to consider as well. For example, SSRIs, they would work better for someone who has got heart problems or cardiovascular problems. I don't know if you want to add on anything more to it, Dr. Kumar.
So it is a very difficult question to answer, and people have tried to answer this question for many years to see, is there a prototype antidepressant that is very effective, safe? There was one study by Cipriani. I think I have a slide for that. Yeah. So there was a study in Lancet by Cipriani et al. So he went on to have head-to-head. He accumulated all the evidence head-to-head between antidepressants, and this is what he's come up with. So it's hard to say one antidepressant as safe and
Better than other.
But in terms of response rate, as you can see, the ones on the right hand side leaning towards right or significantly in favor of active drug. If you look at this, I think amitriptyline, mirtazapine, duloxetine, those seem to be more effective. But again, it doesn't necessarily mean they are equally tolerable and acceptable to patients. So it is a very difficult and complex question. We still don't have an answer for it. What is the most efficacious or antidepressant?
Yeah.
It depends on patient characteristics, patient symptomatology, patient's comorbid symptoms, comorbid conditions.
Yeah.
And side effect profiles. So it's a very complex question to answer.
Yeah. And age group, as you mentioned, if in younger population, you can prescribe fluoxetine in children as well. I mean, liaising with the secondary care team.
Okay. Yes, it's licensed from 8 years above.
Yeah.
Fluoxetine. Only in severe depression in children, you always try and use psychological therapy before considering medications in children.
Sure. Which medications are more likely to cause serotonin syndrome? If I'm not wrong, then most of the antidepressants would cause it. Any which work through the serotonin neurotransmitter would do that, isn't it?
Yeah, all the serotonergic antidepressants are culprits in this. The more serotonin, I mean, the ones that we commonly see are
SSRI, SNRI. Yeah.
SSR and SNRIs. Yes, that's correct. Absolutely.
Sure. Okay. I think probably we have covered most of the questions here. There are maybe a couple more if you have time, Dr. Kumar.
Yeah.
Okay. The question is, people are quite familiar with PHQ-2 and PHQ-9 in primary care. The question is, what are the other questions one should ask in terms of ruling out or ruling in essentials of depression?
Okay, so let me put the slide back so we can go back to those. I mean, I haven't used a tool for nearly 10 to 12 years because I work as an inpatient. I get the extreme end of patient, the other side, I mean, the extreme end of the spectrum. So by the time they come to me, they're needing either ECT or combination of antidepressants and antipsychotics, etc. So I haven't used one for a long time, but let me see what questions that PHQ-9 has got and see if there's anything else we can add to that. Yeah,
I think it's more about while screening for depression. Do you need to look at things like possibility of bipolar affective disorder? As you covered about unipolar and bipolar depression, and is it psychotic depression or psychotic severe depression or without psychotic symptoms?
Yeah.
Yeah.
So perfect. I mean, that is the crux of it. I mean, you can't miss bipolar
Yeah.
disorder because it is one of the most misdiagnosed affective disorder. A lot of people with bipolar disorder are diagnosed either with unipolar depression or other conditions like personality disorder, etc., before they actually present to secondary care in full-blown manic episode. So that is a very important thing that you should probe. You always ask, have you ever had periods when you felt extraordinarily happy and elated? Or has anyone else among your relatives commented that you were high in mood, elated, euphoric, etc.? That is a very good question to ask. In fact, there was a study when I was a trainee, there's a study called Bridge, which looked at how much of bipolar that we miss in routine practice. And it's around 50% of people who eventually are diagnosed with bipolar have had a diagnosis of unipolar depression and treated with antidepressants for a very long time because we haven't asked that one question about bipolarity in the past.
Yeah.
I think the mean time between onset of symptoms and diagnosis of bipolar is nearly 6 years. So on average, a patient has got 6 years of other diagnoses before they're actually diagnosed with depression. I think one of the common things that we do is we miss asking this question. Have you ever felt manic? I mean, that's not the question, but yeah, that's what you need to explore.
Could it be because especially if the patient has got hypomania and when they don't want to see anyone because they already feel on the top of the world, they are happy, they think they are doing really well and wouldn't like to feel like seeing a GP?
Absolutely, absolutely. So especially if it's bipolar 2, where there are lots of hypomanic episodes and a major depressive illness. So if hypomanic episodes are there in the past, I mean, that is something that they may not recognize themselves because, as you said, it's a feel good phase, hypomania, or even mania, and that's one of the reasons why people don't want to take treatment in bipolar because they enjoy being in that euphoric, elated state, happy state.
Yeah, that's right.
Yeah,
So
absolutely. That's a very crucial question to ask in your screening.
indeed. Thank you. Before we just almost, I think we are just reaching the end time. I'll ask two questions together quickly. One is, what would you treat first, anxiety or depression? And the second question is about the dosage of SSRI and antidepressants in elderly people, because general consideration is that you half the dose of an adult when treating the elderly.
Yeah. So when you talk about treating elderly, I mean, I'm not an old age psychiatrist, but the principles are same. I mean, in elderly, I think on average, an average elderly patient that you see is already on 3 to 4 drugs anyway. So be cautious about interactions. That is the main thing. You don't want to make it worse for people while you're treating depression due to interactions and the side effect burdens due to the interactions. So with elderly people, it's always go low and go slow. So you start at the lowest effective dose and try and stick to that minimal dosage that is effective.
Yeah.
And go slow in your titration. That is it.
Yeah. Okay, great. So the question was about what would you treat first, anxiety or depression? Because sometimes they go hand in hand together.
Yeah. So when I talked about mixed anxiety and depression, I think the reason we discussed that is because if someone is satisfying the criteria for both major depression and generalized anxiety disorder, you diagnose them with both of them, not mixed anxiety. Mixed anxiety anxiety and depression is almost like a sub-threshold, and on individual basis, they both don't satisfy criteria for either major depression or generalized anxiety disorder. There's sub-threshold symptoms for mixed anxiety depression. But in case someone's got significant anxiety and significant depression, there's nothing like what takes importance. You got to treat both, and the treatment will be an antidepressant anyway. I think this is where intensive psychological therapy should help with managing anxiety while you're actively treating the depressive symptoms. And this is where, if the anxiety is really disabling, a short-term use of benzodiazepines is acceptable.
Okay, sure. All right. Thank you. Thank you, Dr. Kumar. It was a wonderful talking to you.